welcome everybody to the second part of the webinar series. Well, welcome back to everyone who was here last time, and hello to those of you who I haven't met before. Just a quick disclaimer before we get started that the information that I give in today's webinar and the others as well, it's not intended for the purpose of providing medical advice. It's just for informational purposes and not intended to serve as a substitute for the consultation, diagnosis or medical treatment of a qualified physician or healthcare provider. So please consult someone if you have any further questions. Great, so for those of you who know me, I'll just do a quick recap for the new attendees today. So my name is Amy, I'm an osteopath. I had a background in science before going on and completing my health sciences degree and Masters of Osteopathy. I've then gone on to complete my graduate certificate in tertiary education, which means that I now practice both at a GP clinic and an osteopathy clinic, and then I teach at Victoria University in the osteopathy degrees. All right, so today's session, we'll be doing just a quick recap of some of the important parts about the musculoskeletal system in general. Then we'll dive into the muscular system and some common conditions. And as Fatih said, there's a list of terminology available for you for any of the words that you're not sure of to come back to. And I really encourage you to add to that as you do learn more terminology as you go along. Okay, so I'll have a quick recap of the musculoskeletal system. So a really important concept that will follow through today, like last time, is that of structure versus function. So just remembering that structure governs function. All of our anatomical structures are designed to perform a certain function. Changes in that function can cause changes in the structure and vice versa. So we're going to see that a lot with the muscular system because the way that the muscles are designed, and each one is different to each other, determines what role they play in our body. Good, so we've got all of our body systems. We had a look at the skeletal system last time. This time we're having a look at the muscular system. Next time we'll dive a bit further into the neurological system and how that relates to pain to bring that all together. So as you can see here, when we come down to the tissue level of organization for the human body, we can have muscle tissue in the middle here. And we have three types of muscle tissue, so skeletal, cardiac, and smooth tissue, which is found in our organs. Today, as we're really focusing on the musculoskeletal system, we'll just be looking at skeletal muscle, but it's important just to recognize that there are a few different types of muscle throughout our body. So the components for the musculoskeletal system, we have our bones, which meet together at the joints, our muscles, which pull on the bones to create movement. We have cartilage lining the joints. Tendons are the part that connect the muscle through to the bone. Ligaments connect bone to bone, and all of our connective tissues helps to bind all of these other tissues together. Right, there are functions for our musculoskeletal system: to support our body physically, to provide movement. We spoke a lot about protection in the last presentation. Today we'll maybe think a bit more about heat production and movement for muscles, and we can also have our blood cell production. It's useful, again, just to review this anatomical position. So it's our reference position for describing any directions or locations, and to be familiar with these directional terms. So if a lesion or an injury is being described, you understand what that's referring to. Okay, so onto the muscular system. So skeletal muscle, whenever you see the prefix myo, so any kind of word starting with myo, that means that it will be referring to muscle. So muscle is a really specialized tissue. It has both contractile and conducting properties. So contractile means that we can contract the tissue so it becomes smaller or shorter. Most people should have heard about contracting a muscle. And conducting means that it can transmit energy. What we're talking about specifically there is electrical energy from the nervous system, which is our communication pathway that tells the muscles what to do, what movement to produce, and how to contract. So our skeletal muscle is voluntary, so we consciously control it, whereas if you think about what's going on in your organs, say your digestive system, which is lined with muscle as well, we don't have control over that in the same way. Cells in our muscle are called muscle fibers. They may also be called myofibrils or myofibers, so keep an eye out for those words changing. They're long, thin cylindrical cells that run parallel to each other. We'll have a look at that in a moment. And they're held together by connective tissue sheaths, and they become important because they can actually be injured themselves. So the importance of the muscular system is the ability to create force and movement. Doing this, it uses up a lot of energy. So the main energy that we have in our cells is called ATP. And we have action potentials, which is the electrical signaling from the nervous system that comes down to the muscles, tells them to contract, tells them to produce heat and movement. So if you think about shivering when you're cold, that's actually really fine movements of your muscles in order to try and produce heat. So because they are using up all of this energy and there's so much signaling that has to go on for this to occur, it means that we need a lot of blood flow to the muscles. So they're highly vascularized. So they have a lot of blood vessels going through them to bring through oxygen and to bring through energy and to take away any of the byproducts of their contraction. So if you think about if you've been to the gym, or if you've done a hike, if you've just done a lot more activity than what you're maybe used to doing, and you pull up quite sore afterwards, that's because after all of that energy is being used up, there's byproducts that are produced. And then when they're still present in the muscles, that makes them really sensitive. So you might find that the next day, or even often 2 days later, all of a sudden you think, oh, I can barely stand up or sit down or walk down the stairs, something along those lines. That's all to do with that energy use and production in order to get all of those contractions happening. Right, so our characteristics for muscle, so excitability, so that's responding to the stimulus through the nervous system. Contractibility, or contractility, is the ability to forcefully shorten. We need the muscles to be able to stretch or lengthen, so that's extensibility. And after they've stretched, we need them to be able to recoil. So go back to the original size or shape. So that's known as elasticity. We have many different muscle types, and the shape of the muscle helps to determine the movement that's produced. So if we have a look at a few of these examples here, if we see these parallel muscles, such as in example D, those two can work with each other to produce more force. Whereas if we have a look at example A, which is a circular muscle, and that one that's listed there, the orbicularis oris, is actually one of the muscles circling our eye. And if we imagine if that was to become smaller, that will actually constrict or decrease in size in that way. So again, if we come back to that structure versus function, the structure of the muscle really determines what movement it can produce. Combined with that, we have different attachments for the muscles. So we have the proximal attachment, which is also known as its origin, and that's the attachment that remains fixed or moves the least. Whereas the distal attachment, or the point in which it inserts, is the attachment that moves the most. We do have some exceptions to this. So we're going to use the bicep muscle, so which is the top part of your arm here, as an example for quite a lot of these, just because it's easy to move yourself and to understand. So our bicep muscle will bend our elbow. So it brings your arm up like that. So that's if you think of like a bicep curl is a common exercise in a gym. So if we were to think about the proximal attachment is up here at the shoulder and the distal attachment is down here at the elbow. So when we contract the muscle in that way, that distal attachment down here is the one that's moving the most. My shoulder isn't really moving, but down here at my elbow, I am getting movement. So have a go of that yourself, just so you really understand that. Now, if we then looked as a comparison at a push-up, so if my hands are out in front of me and then I was coming in towards it and doing like a push-up type movement, if you feel that, you can still feel your bicep moving. But because my hands are held down against the floor or a wall or whatever I'm doing the push-up on, that means that my elbow stays relatively still, but my shoulder is actually moving towards the hand instead. So sometimes those can flip around. So it's a useful way of understanding where the muscle goes to and from, but there's always exceptions, which is the golden rule for the human body, is that nothing is ever exactly the way that we say it. There is always exceptions, just to make things difficult for us. So the location of those attachments, whichever way we look at them, and the joints that they cross determine the movement that we produce. So we then have some different subcategories of muscles. So a prime mover is known as the muscle primarily responsible for a movement. So in that case of bending the elbow, our bicep muscle is the prime mover for that movement. So a fixator is a muscle which stabilizes one part of the body during movement of another part. So it allows that prime mover to do its job. So if you have a think about if you wanted to lift your leg, so even from that sitting position, if you want to lift your leg, so you get movement at your hip, if you didn't contract your abdominal muscles as you did that, you'd just slump down and you wouldn't be able to do the movement. So we actually need to be using those muscles in our abdominal region in order to use our legs. And there's examples of that all through the body. Synergists are muscles that work together. So if we have a look at this example in the picture here, our brachioradialis down the bottom, which is this long muscle in the forearm, that's helping the biceps muscle in the upper arm to produce that movement of elbow flexion that we've just been speaking about. So they're working together. Whereas if we looked at the antagonist muscle, so the muscle that works oppositely to the bicep, so if the bicep brings the elbow up, the muscle that brings the elbow down into extension is the name of the movement, then that would be our triceps muscle, so the muscle through the back of the arm. And again, we'll see that pattern repeated. So our quadriceps, for example, or our quads as I've shortened it to there, is the muscle at the front of the thigh, whereas the hamstring, which is the group of muscles at the back of the thigh, they work in opposite ways to each other. So we have that happening all throughout the body in order to provide stability, and so we can move in all directions as well. So we've had a few muscle names already, and they probably sound quite complicated. But if you understand the way that the naming of the muscles comes about, then it can help you kind of problem solve and figure out where they come from. So there's a few different conventions that are used for naming muscles. One of the first ones may be the location. So if you see the term brachii, that means that it's going to be up in the arm. So we've already seen biceps brachii and brachioradialis. So you see that pattern followed for arm muscles. If something's called the pectoral muscle, so pectoral major and minor, that's going to be in our chest region, and most people have heard about your pecs. So that's where they would come from. We can also name it by the number of the heads. So I just mentioned biceps brachii and triceps brachii. So the biceps brachii, you can see here in the picture on the left, there's two heads. There's a short head and a long head. Whereas for the triceps brachii, there's three heads. So you have the lateral, the long head, and then the medial head as well. We can name the muscles by the shape. So a quadrate muscle would have four sides. So with quad meaning four. So an example you can see on the right here is pronator quadratus. Good. You can also name them by how long they are. So brevis meaning short and longus meaning long. So the movement that they produce is another really common one. So look at extensor digitorum. So that extends the digits, which you can see in the name there that comes together quite clearly. When we come back and look at that pronator quadratus that's in the photo there, pronation is the movement of turning your arm over that way. Yeah, so supination is this way, just like you're carrying a bowl of soup, and pronation is turning over that way. So the name of that muscle, pronator quadratus, describes that it pronates the arm and that it's got four sides. And then we can get really fancy and go for these big combinations like flexor carpi radialis longus. And that means that it's a long muscle that produces flexion between the radius and the carpal bones, which the radius and carpal bones, if we remember back to the last presentation, the radius is a bone in the forearm and the carpal bones are the bones of the wrist. As you can see, you kind of need to bring all that information together about the skeletal system and the muscular system to really make sense of the whole thing. Good. Our next topic is tendons. So these are a dense form of connective tissue. and they're covered in a protective sheath, which is important when we come to our common conditions later. So this is the point where muscles then change into a tendon and then attach into the bone. And they basically withstand the tension and transmit any forces from the muscle into the bone. It's their job. Through doing that, we have a look at the different movements that they can produce. So, as I mentioned earlier, any joints that the muscle cross, they're the ones that they're going to be able to move. So if we come back to our example of the biceps brachii in our arm, so we have the long head coming up to the shoulder blade on the outside, and the short head coming up to another part of the shoulder blade just about here. And then the distal attachment is onto the radius in our forearm, which we just mentioned before. So this muscle crosses both the shoulder and the elbow joints even. That means that it can work over both those joints to produce movements. So its actions are that it moves, it's on the front of the arm. So if we think about just with the fact that it lies there, it makes sense that it has to move that area forward. It can't really, if we think about it contracting, so shortening from here to here, then that's going to bring this area up. It can't really move the arm backwards. And then it also has movements at the elbow because it crosses that joint. We mentioned flexion already of the elbow, and then supination was the one where you turn your hand over like you're going to hold a bowl of soup. Good. I'm not going to go through examples through the entire body because there's so many muscles everywhere. I should have looked up an exact number. I'm not sure of it off the top of my head, but if anyone's got Google open and can bring that up, that would be great. Probably a helpful thing to know, but yeah, we'll just be giving examples all the way through, as otherwise we will be here all evening. Okay, so muscles and their contraction. So as we've already established, muscles pull on bones and they act as levers and produce movement. So each muscle is supplied by a nerve, which gives that signal and the information telling it what to do. That means that our conscious movement starts up in our brain. So when we decide that we want to actually perform a movement or we want to do an activity. We can also have some unconscious movement that's producing muscle movement, or some unconscious decision to produce muscle movement. And that's when we get our reflexes happening, which we'll have a little look at in a bit. So just some very basic nervous system information for you. So here you can see our primary motor cortex. This is a picture of our brain. So this is the brain stems at the bottom there, and the rest of that area is known, the big area in blue is known as the cerebral cortex. So we have this one area of our brain that's in the purple colors, that's called the supplementary motor area and premotor area. So they're the areas that work when we're deciding to do something, but before we've actually started to initiate the movement. And then our primary motor cortex here in the kind of brighter purplish color, that's where we get all of the signaling coming when we decide that we want to make a movement. We also need information coming back about what's happening in our body. So we need sensory information coming back to our brain. So right behind the motor area here, you can see that we've got a primary somatosensory cortex. So that's getting all of the information back from our skin, our muscles, and our joints, saying about what's happening in the body so we can keep refining our movements as we do them. So for example, if you went to reach out for something that was moving, we need to have that constant feedback coming through, telling our body about that move, about the object and where it's moving to, so we can refine our movement and still make contact. In these areas, we have what's called a homunculus. So it's a distorted representation of the human body based on the neurological map. So the proportions of the brain that are dedicated to the motor and sensory functions of our different parts of our body come up in different ways based on how sensitive the area is. So if you think about how sensitive your fingers are, so they're very sensitive to touch. We also have lots of fine motor control. Or if you think about your mouth, where we need our tongue, our lips, and our mouth to all work really well together to produce all of the different sounds that we can make. And that's also really sensitive to, you know, hot, cold, and all those types of things as well. That means that those areas have a lot more brain dedicated to them. So if we have a look at it here, you can see that it looks quite funny the way that it's all mapped out. And in both of them, you can see that the face, and when we look at the motor part especially, the mouth and the hand is really large. So that just is a representation of how much of our brain in those areas is dedicated to controlling and receiving feedback on those areas. So we might have a little bit of a further look at that in the next presentation, but it's really quite fascinating once you start to get down into it and have a look at the way the brain controls everything that we do. So once we've made that decision that we want to move, it starts in the brain, we have to get that information out to our muscles. So that happens through the spinal cord. So the spinal cord is continuous with our brain, and then it runs down through our vertebral column, and then we have other little nerves shoot off down to out to the sides and come out and supply all of the different areas of our body from there. So similar to what we spoke about in the last unit with back pain and when we had radiculopathies, we have the different levels in the cervical, thoracic, lumbar, sacral and coccygeal region. The different segments produced different levels of nerves, and those nerves supply very specific muscles, and those patterns are repeated in everyone. So that really helps us to make diagnosis of what's going on, because we can look for those repeating patterns. When those nerves come out of the spinal cord and they go out to the muscle, we then have what's known as a motor unit. So a motor unit, it's known as the functional unit of the muscle, because everything that we need for contraction to occur is technically there. So it's a single nerve and the muscle fibers that it controls. So each of those muscle cells that it goes out to control. So we can have one nerve going to one muscle fiber, or we can have one nerve going to thousands of muscle fibers. And that just depends on the size and the function of the muscle. So there'll be a difference between, if we want really fine motor control, then we want lots of nerves going and innervating that one muscle. Whereas if we're just looking for strength, but we don't need so much control, then we can have less nerves going out to the muscle. And then based on that, depending on how strong we want to contract, so depending if we go to lift something up, if we know it's quite light, we only need to use a few of those motor units. We only need to get few of the muscle fibers contracting, whereas if we want to pick up something really heavy, then we're going to get lots of those motor units working and lots of the muscle fibers contracting to produce lots of strength. So we have three types of muscle contraction that we can do. So concentric contractions, that's when the muscle shortens. So if we come back to our example of the bicep here, when our elbow bends and the muscle shortens, then we get a concentric contraction. So if the muscle is contracting as the muscle lengthens, so if you imagine, like in the photo here, you've got something heavy in your hand and you're going to put it down, we don't just want to drop that, we want to control the movement as we go to put the object down, and that's when we get an eccentric contraction. So it's a contraction as the muscle lengthens. And our third type is an isometric contraction. So the length of the muscle doesn't change in the contraction. So if you're holding something in your hand and you're just holding it at the same point, the muscle is continuously contracting, but we're not producing any movement. So we need all three of those. And then if you are training your muscles for certain activities, they become really important, because you want to think about what you want the muscle to be able to do and train it in the appropriate way for that. So there's, they all have their individual uses, each type of contraction, but ideally, if you really want to be able to lift something and move the elbow joint coming up and doing that curl type movement, then you need to practice that and train the muscle to be really efficient and strong to do that particular movement. Good. So I mentioned reflexes earlier, and they're just an interesting one, as far as I've just said about how most of our instruction and processing to be able to produce some movement starts at the brain and then works its way down. However, we have these reflex muscle contractions, and they're really there for safety. So if you can imagine, if you've put your finger on something that's really hot or sharp, and how you've actually pulled your finger away before you've actually really consciously noticed that the surface was hot and you might burn your finger. So they're really important for that protective mechanism, and we have them from a very young age, which is also very helpful. And what happens here is that we just get the signal coming from the finger. It runs up through the nerve that goes to the spinal cord. Now, instead of that information having to come all the way up to your brain and your brain thinking, oh, yeah, that feels hot, that might cause some damage, let's pull the finger away. We get to this point in the spinal cord, and then we've already gotten this reflex reaction. So this is where it becomes important that we have those muscles that work in opposite ways to each other. So we get that reflex reaction to contract the opposite muscles and bring that finger away from the source before we cause, well, hopefully before we've had any damage. The information will then be sent up to your brain. So that's why you then go, oh, that was really hot. I'm glad I pulled my finger away. But the actual movement has occurred for safety reasons before your brain's actually consciously told your body what to do. So there's a few different reflexes that are around. That's kind of the main one and the one that you'd be most familiar with, but they're quite fascinating that we've got them set up to really protect us. All right, unless there's any questions, I'll move on to the investigations.
All good for now, Amy, thank you.
Great. So we have some different investigations that are done for the muscular systems. So we have lab tests. So these will generally be blood tests, and they look for a few different things that are specific to muscles. So if they just want to check if there's a lot of inflammation throughout your body, so generalized inflammation, there's different what are called markers that they can look for, such as this one here, which is called the erythrocyte sedimentation rate. And that's a fancy way of saying how quickly do the red blood cells gather when the blood is spun around really fast. So, and there's different rates, like there's different standard rates that occurs at that says how much inflammation is in the body. They might look for antibodies, which are immune cells, and that would be if they're suspecting an autoimmune disorder, or they might look for particular genes that you have. So a common one is HLA-B27, and that's present in a lot of rheumatological conditions or different types of arthritis that have, so some of them we mentioned last time, such as rheumatoid arthritis or ankylosing spondylitis, are some that this is a predisposing factor to get to develop the disease. So they might look for those in helping in diagnosis. Ultrasound is a really useful imaging technique that's used for soft tissues. You might also see it referred to as ultrasonography. And this uses high frequency sound waves to produce images. So they use the probe and run it over the area. The sound waves travel into the body and bounce back off the different tissues depending on how dense they are. And then we get a map of structures. So you can see over here on the right, the top image is actually an MRI. So we can see lots of different information there about all the bone around the heel and going up into the leg, and then the soft tissue around the bottom of the heel. And the Achilles tendon is the part that the arrows are pointing to. And then the bottom area is showing an ultrasound. So you can see that it gives a lot less detail, and really it's only shown the Achilles tendon here. And it's just shown how thick it gets in some portions of it. So we can have two types of ultrasound. We have structural ones, which show a map of the structures in the area, and then functional ultrasounds, and that can show movement and velocity of tissue or blood. It can show a bit about how soft or hard the tissue is, and some other physical characteristics as well. X-ray shows bone and some general outline of soft tissue. It's not actually used to see the soft tissues themselves, but it will be used in soft tissue injuries to see if there's been any bony involvement or if there's any calcification in the muscle. And they use radiation, as we discussed last time. We have our CT scan, which again is using X-rays and produces this cross-sectional image. So it provides more detailed information compared to ultrasound and X-ray. It will be used generally if you're going to, as a general rule, if you're going to get a CT scan for a muscular injury, they're probably giving you an MRI unless there's a safety reason why you can't have an MRI. Just because if we jump to the next one, the MRI, you can see just how much more detail it gives you of all of the soft tissues, so all through the brain and through the spinal cord there. Good. Our last one is our nerve conduction studies and electromyography. So as you've probably figured out by now, the muscular system is very dependent on the nervous system. So we need all of that signaling, all that messaging and information through the nervous system to tell the muscle what to do. So if the nervous system isn't working well to give that instruction, we're going to have problems with the muscular system. So we could do nerve conduction studies, and this looks at how well the nerve is supplying the muscle. And then electromyography. So in that case, we're looking at how well the signal from the nerve is actually being transmitted into the muscle. For those reasons, they're often performed together. So we can use these for some specific muscular problems. Myositis and muscular dystrophy we'll talk about shortly. We can also use them for nervous system problems or problems where the two of those meet up, which is at the neuromuscular junction. Great, so we'll move on to common injuries now that occur within the muscular system. Throughout this area, again, I've just chosen some of the most common injuries and, well, should be injuries and conditions that occur. So, for example, the first one that we're going to talk about is a muscle strain or tear, which I'm sure a lot of you have some history with at some stage. I haven't gone through every muscle because the patterning is the same for all of them. So this just gets applied into each muscle as it occurs. So a muscle strain or tear occurs when the muscle is overstretched. So this can be an acute event, so an acute overstretching, or chronic, so happening repetitively. There's a few different levels of grading, but generally it's graded either 1 to 3 or 1 to 4 sometime. Grade 1 is a strain without any tearing of fibers. Grade 2 includes partial tearing of the muscle, and grade 3 is complete rupture of the muscle. Those gradings also apply into tendon strain or tear as well. If there's a 4th grade, that just means that the middle section in grade 2 has been split up into 2 different levels. So muscle strains and tears are very common. I'd be surprised if any of you hadn't at some stage lifted something too heavy, done a big workout, been for a big walk, or something if you've been, out in the countryside or traveling or something like that, and then pulled up quite sore the next day from it, or even for a few days. If it's just for one day, that's probably more what's known as DOMS, which stands for delayed onset muscle soreness, and that comes back to overuse, meaning that you haven't gotten rid of a lot of the byproducts of the energy use that you've accumulated during that activity. Whereas if your soreness is lasting for kind of days to weeks, then that's when you're looking more that you've actually strained the muscle. So these are really common, especially in muscles that cross more than one joint. Can anyone think of, based on what we've spoken about already, can anyone think of why that might be?
You can go ahead and type in your answers and I'll read them out to Amy.
Great. So if we can get some.
So is that why footy players, no matter how cold the water is the next day, you see them kind of, walking through the beach on St Kilda in the water? Is that to get rid of the energy in the muscles?
Yeah, that's right. So going between that, using heat and cold therapy, especially when you'll see them going out into there, but often after the game, they also have like cold baths, and they'll go between heat and cold a few times, or at your local footy club. if you're ever in one or any sporting club and you see some like big wheelie bins and they have a hose going into them, that's usually the at-home version of filling that up with cold water and jumping in and trying to stimulate the circulation to try and flush out.
That's a
any
good
byproducts.
way of bringing the beach to the backyard. Fill up
Yeah,
a wheelie bin.
exactly. So a bit of DIY works just as well.
Yes. You want to type in your answer? What was the question again? Maybe we just remind the question.
Why might muscles that cross more than one joint be prone to strains or tears?
Anyone? Any takers? Just to make sure that.
It's a harder one. It's a harder question, but.
I think everyone's waiting for someone else to answer, so I'll divert the question back to you, Amy.
Okay, no worries. So the ones that are most commonly injured in this way are hamstrings, the quads in the front of the thigh, and the calf muscles. Hamstrings, probably anyone who follows sport knows that they're a really big problem in the sporting field. And that's because if you think about what they're having to do, so when we want the muscle to contract to control movement at that joint, if they're crossing more than one joint, they're trying to control two things at once. And those joints might actually be working in kind of opposite ways or asking different things of the muscle at once. And that's where it becomes really problematic. So if we have a look at this, the third point, where tears are most likely during change of direction or change of speed, such as either pushing off or decelerating, that's because we're suddenly asking the muscle to perform a very different task to what it was doing a moment ago, or it trying to work against itself over the two joints that it crosses. So lots of predisposing factors to why you might strain a muscle or tear it. Overuse, when you get fatigued, you're more likely to get injury. Improper use, poor technique in whatever it is that you're doing, and that can be sporting or just your household chores. And they also increase with age as well. The healing time is a little bit variable. If it's just a minor strain or grade 1 strain, usually it's after a week or two, it's feeling pretty good. But if we're up in those grade 3s and we get tearing, especially if surgery is needed, then we're looking at months for recovery. The important thing to remember with the whole musculoskeletal system is after we've finished feeling symptoms, we're still getting remodeling of these tissues occurring for a few months. So we really have to look after ourselves during that time and try not to overload the area again. All right, a couple of conditions that we'll look at. The first one is myositis. So myo is our muscular prefix that we spoke about. If we can remember from last time, situs stands for inflammation. So this is inflammation of a muscle. There's lots of different things that can cause it. However, usually when we see the term just on its own, it's used to describe what are known as just the inflammatory myopathies. And you can see a list of these over on the right side there. And that's taken from the Myositis Association. So that's listed as one of your areas that you can go to for more information if you ever need help with this. It is quite a rare condition. And unfortunately, what that does mean is that there's not a lot of funding that's being put towards it. So there's not a lot of treatment options. So we see people with myositis get weakness and swelling and atrophy, which means decrease in size of the muscle. And really, it's just treated with immunosuppressants, so medications that decrease the amount of the activity of the immune system to stop it from attacking the muscles. And then also with steroids, which are used to decrease inflammation. The issue which we might remember with steroids from the last presentation is that steroids, they will decrease inflammation, but they also have negative effects on our tissues. So they will lead to the tissues degenerating. So and you'll see that steroids are used for a lot of the conditions that we're going to talk about. They're a really common treatment method, but we have to be really clever in the way that they're given and not give it too much to the point where it actually causes degeneration of the tissue. For some conditions such as this, that's going to be, a less, someone needs the medication, so it has to happen. But for some of the other conditions that we'll look at, where we can actually really do exercise rehabilitation and get recovery, then we try and minimize the amount of steroids if possible, as a general rule. Muscular dystrophy is probably one that you've all heard of. So it's a group of inherited muscle disorders, and abnormal genes are responsible for muscle structure and function not developing as it should, and then muscle weakness occurring from there. There's a whole range of different ones that occur, and you can go to that Muscular Dystrophy Australia for more information on the individual ones. And you'll see that some begin in childhood, that's the most common form. Others begin in adulthood, and depending on the form of them, progression is variable. So for some people, it just affects more their peripheries, so they'll get weakness in like their hands and feet. Some of them tend to affect more the more central muscles, and in those cases, it might actually affect your ability for your muscles to allow you to breathe, or for your digestive system to work or something like that, which is obviously a lot more serious. For diagnosis, that's when we'll look at our blood tests, use the electromyography, and also use some biopsies. So take a sample of the muscle and look at it under the microscope and do some testing from there. Unfortunately, there's no cure for these. Medications can be used to try and control some of the effects. It might have surgery if needed, if the way that the muscle's working is stopping you from using that area of your body. And if breathing is affected, then ventilation could be needed as well. Good. Myasthenia gravis is when so we've looked at myositis, which affects the muscle itself. Then we've had a look at muscular dystrophy, which affects the muscle structure and function as well. So myasthenia gravis is when the junction between the nerve and the muscle is actually damaged. And this is another autoimmune condition. So when our immune system starts attacking itself. So our immune cells and the antibodies that they produce attacks receptors on the surface of the muscle. So if we have a look at this diagram here, which contains more information than you need to know, but the top section, that's a nerve coming down and meeting up with the muscle, which is along the bottom. And down the bottom on the muscle where you've got the little square kind of divots coming out, the bright green thing that kind of looks like a cactus coming off it, that's the receptor. So those little receptors are attacked by the immune system, and that means that the communication with the nerve can't happen as it usually would. So this will result in weakness. So it's the muscle isn't getting the signal to contract, so we're not getting the contraction in the same way, and you can get weakness of often the muscles of the eyes and face, neck, throat, and then sometimes into the limb or trunk. And this most often is in women between 20 and 40 years old, or men over 50. And the progression of that varies depending on the extent of how much the immune system is attacking itself. So usually that can be controlled with drug therapy, so something like immunosuppressants, or removal of the thymus gland. So the thymus is a gland that produces those antibodies and immune system cells. So if we remove that, we get less action of the immune system, so it stops attacking the body.
I've got a question, if you don't mind, Amy. What is electromyography?
Yep, so electromyography, if we jump back to that slide, that is that's where we can perform. So they use, they'll insert, what's the word I'm looking for? They'll insert, a probe or a needle into the muscle, and then they'll send in kind of electrical signals. So not an electrical shock, it's much lower than that, but they'll send in electrical signals and they'll check how well the muscle is responding to those signals. Does that make sense?
Yep, and so that's used for muscular problems you were saying, like myositis and muscular dystrophy. So is that a way of testing if they have it or not?
Yeah, it will give more. It doesn't so much tell you, it doesn't give you an exact diagnosis of that condition, but it gives you some information to know that there is a problem with the muscle responding to the electrical signals. And then it can also be used for monitoring the condition. So looking at how affected the muscle is, and how affected muscles around the body are, and then deciding on what appropriate treatment is needed at that stage, and yeah, monitoring progression over time.
So if we were to break that word down, we're saying myo is muscle,
Yep.
And electro is electricity, and
Yep.
graphy is like a
It produces a graph at the end of it.
Yeah.
Yeah.
So for us linguists out there, it's a graph of the muscle with, so we start from the back, don't we? Graph of the muscle with electricity, along those lines, maybe.
Yeah, essentially, yeah.
Thank you.
Yeah. Any others or?
Good for now, thank you.
All right, cool. All right. So we'll have a bit of a look at tendon pathology. So if we see the word tendinopathy, so if anything that's like pathos or pathy, that's taken from Greek for disease. And these are really for the tendinopathy. We'll go into detail what this means in a bit, but these are common in the rotator cuff. So I'm sure a lot of you have heard of someone with a rotator cuff injury before, very common. The Achilles, which is the one at the back of the ankle, and tennis elbow is another term probably heard of. We can have tenosynovitis. So if we break down that word, synovium, it means the tendon covering. Itis is inflammation, synovium means covering, like a sheath around something. Itis is inflammation, and teno for tendon. So the tendon covering is inflamed. And then the last category is tendon tear or rupture. As a general rule, tendons have quite a poorer blood supply compared to muscle. So we spoke about how muscle has a lot of blood supply to it to help with its function, provide lots of energy and oxygen. That also means that it's quite good at healing because it's getting all of the things in that it needs to heal really easily, whereas tendons have a poorer blood supply, so they take a lot longer to heal. For all of them, graded exercise rehabilitation is the key in recovery from them. So always good to do your rehab. We're just going to start off with having a look at tendon ruptures. The interesting thing with tendon ruptures is that if it's a full rupture, it can often be painless. And as we've said, we're going to explore pain a bit more in the next webinar. But if the nerve supply to it is essentially cut off because it's completely ruptured, then you just might not feel pain. And you can see in the photo here, that's someone's bicep. So down at the elbow there where it's really bruised, that's where the actual rupture has occurred locally. And then that whole bicep is sitting up in the top of the arm like a ball. So when that happens, you'll actually see the whole muscle just come together at the other end and bunch up. And depending on if that happens, often they'll get surgical repair, depending on what the muscle is, how old the person is, and what their functional activities are. So, someone who's playing high level sport and is in their 20s compared to someone who is in their 90s and then only doing light activity that they can still do even though that rupture has occurred. Those kind of things will help decide what the intervention is. So our most common ones are that rotator cuff, bicep, and Achilles. And they're often, those two don't just stand for the Achilles tendon, but they're usually caused by, an acute situation. Foosh means fall on outstretched hand. So if you can imagine you fall over with your arm out in front of you and land on it, that can cause issues all the way up the arm and into the shoulder. overloaded if lifting a weight, or repetitive strains. So if you keep doing an activity that overloads a little bit again and again, especially with age, as we start to get a degenerative change that naturally occurs, then that becomes more likely.
So a word that sounds so pretty, but when you open it up, it just doesn't sound as pretty. Foosh. Interesting one.
It's a good one. Great, so then if we move on, that's our tendon ruptures. So now we'll have a look at a few tendinopathies, which are common. You'll see, I'm sure a few of you out there have had one of these, or a family member has. So lateral epicondylalgia. This is also known as tennis elbow. The reason why it's called lateral epicondylalgia in the scientific term is because it happens at the lateral aspect of our elbow, so the outside of the elbow, and the bony point here that the tendons insert onto. So if you look at the picture and you see where the red points all meet up, that's called the lateral epicondyle. So that's a bony point on the humerus, which is the bone of our upper arm. So that's where the name comes from, essentially. So we get degeneration or dysfunction of the tendons that extend the wrist, so that cause your wrist to do that movement. So come back that way, and those muscles cross over the wrist into the hand and come all the way up to the elbow there. This is really quite common. So 1 to 3% of the general population, which is fairly high for a musculoskeletal injury. It's called tennis elbow because around 50% of tennis players will have it at some stage in their career. But generally, in the general population, it's most common in 40 to 50-year-olds, and both males and females. And we can have an acute or a slow, which is what insidious means, onset.
Does it only happen when these 40 to 50-year-old men and women pick up tennis at that age, or is it just it could happen any other time?
No, it can happen any other time, and it just depends on what your daily activities are. So if we have a look at the list of causes here, which are more which can be linked into kind of any profession and tennis or activity. So we can have overuse, you're just using the muscles and the tendons repetitively too much. We can have technique issues, so that could be the way someone is holding their tennis racket and swinging it. So if, say, they're swinging and they're getting a lot of that movement happening with their wrist coming back as they follow through, that might cause it. But similarly, for someone, if they're hammering, I'm trying to think of a way to do that, if they've got their wrist pulled back that way and then you're hammering doing that with your wrist, that can cause it. So you see it in quite a lot of tradies. Or if you're typing and your wrists are pulled back like that, and then you're typing or using your mouse a lot, depending on where your keyboard or your mouse are placed, that can also cause it. So we see it in a wide range of different, kind of activities and employment. As far as investigations, we can have that ultrasound, as we said earlier, is really good for tendons. We saw that Achilles tendon. MRI is considered the gold standard, but generally due to the how long the procedure for an MRI takes and the cost, that will really happen just if it's not responding to treatment. And you can also try an anesthetic injection to see if the pain is relieved, and that can give, just if you're thinking, sometimes it can be a little bit confusing, and you might be thinking, oh, could be the tendon that's causing problems, or it could be a nerve that runs through to the area that's causing problems, or something bony that's causing problems. A local anesthetic injection can help to clear up that information. As far as treatment goes, and we're going to see this repeated for pretty much all tendon problems, so I'll go through it here and then can just recap for the others. Manual therapy, so getting some hands-on treatment as far as massage or dry needling therapy goes, can be helpful. Definitely need to modify the activity, so you've got to address the causes, the reason why it's happened, otherwise it's likely to just keep going on. Exercise rehabilitation, as I mentioned earlier. Can use anti-inflammatories if there is a lot of inflammation around. In these tendon problems, there doesn't tend to be a huge amount of inflammation that's actually occurring, because it's usually it is far more common for them to be something that's occurring because of repetitive movement, so you don't get a lot of inflammation occurring there. We can use bracing to try and limit the amount of movement occurring in the area and allow the tissue to start to heal. As I mentioned earlier, corticosteroid injections can be used, but as I said, there's generally not a lot of inflammation around, and because they do cause issues with causing further degeneration of the tissues, they're not the best for them. And then shockwave therapy is a newer therapy that's come through. It looks similar as far as a machine goes to an ultrasound machine, if you've seen one before. And it's similar in the way that it's sending in sound waves into the tissues, but they're just a different type of sound wave. And what shockwave therapy does is it stimulates the release of a lot of those products for healing that we need. So things that are coming in through our blood vessels. So we get a lot of those different components that we need for healing coming in, so that can start to happen more effectively. And then if 12 months of conservative treatment hasn't worked, then surgery will be looked at. But it is quite normal for these tendon problems to take months and months to really resolve. So it's quite normal, especially if it's been around for quite a while, that someone will take 6, 9, 12 months to actually recover. They are slow healing. We don't actually tend to see that the dysfunctional or degenerative tissue that's there actually heals itself. We tend to actually get the laying down of new tendon tissue around the old dysfunctional tendon tissue, and that just takes time. So, and that's for the reasons that we spoke about with the poor blood supply and not getting a lot of those things that we need for healing of the tissue to actually come in readily. So we tend to just build new tissue. Hopefully that makes sense. On the opposite side of the elbow, we can have medial epicondylalgia, which this is often known as golfer's elbow because lots of golfers can get it. It's a lot less common than the lateral version of it, and that's caused by, so when I said that for the lateral side, it was our wrist extensors that were causing it. If we flip to the other side and it's down here, it's going to be our wrist flexors, so the muscles that lie along here and pull the wrist down that way that cause this one. And everything else about it as far as investigations and treatment is the same. Except just for the opposite group of muscles, of course. So we can have rotator cuff problems, and I mentioned in the last one about bursitis. So they often come together. So go back to that one if you want a recap on the bursitis. So our rotator cuff, it's a group of 4 muscles. So you can see on the back of the shoulder here where the arrow is pointing down. So that top muscle, so that one's known as supraspinatus. Then just below that is infraspinatus. Then below that you have teres minor, and on the opposite side of the shoulder we have subscapularis. Those 4 muscles all come from the shoulder blade or the scapula and go out to the humerus or the upper arm bone, and they act to control shoulder movement and to stabilize that shoulder joint. So we did mention last time about how the shoulder joint is a ball and socket joint and how it comes together like this. But it's often spoken about how this part is like a golf ball sitting on a tee. So they don't match up very well size-wise, which gives us lots of movement of our arm, but it does mean that we need these really strong, capable muscles to control that. So if over time we get repetitive strains or there's an acute injury that means the muscles can't cope with the force going into the shoulder, or as we age, those muscles do have some naturally occurring degenerative changes, then we can get a strain, a tear, or a tendinopathy, and all of those are really common injuries to occur. So as I said, age, repetitive shoulder actions can help or can contribute to the cause of this. Poor healing from trauma, workplace factors, if you've got a job that requires repetitive use of the area, there seems to be a genetic link. And poor general health. So if you've got poor general health, that includes increased BMI or so body mass index or being overweight. If you've got poor circulation, and conditions that might come along with that, such as heart disease or diabetes. All of those mean that you're more likely to get injuries to that rotator cuff. And we'll use imaging techniques for that. So usually starting with an ultrasound and then can move up to CT or MRI is the one that gives us the most detail as usual. So again, treatment, exercise, manual therapy, medications, if really needed, surgery. The Achilles tendon is another one that's really common. We'll look at this as an example of a lower limb one because there's a few different reasons why these might start to occur. Particularly, we'll see in this risk factor list here, starting new exercise or a training program or a change in the equipment that's used or the surface. So if you go from from a softer surface such as, I don't know, walking or running on soft grounds like dirt or grass into a really hard surface like concrete. If you have a change of footwear, so if you get new runners or for some people, if they get high heels that they start wearing to work every day, they can all contribute. We see this a lot in runners, again, increasing with age because we get decreased tendon health, more in males as well. So this is often known as an injury that occurs to weekend warriors, and often it's spoken about how men in their 40s and they think, oh, I need to get fit again, I want to get active, and they start running and they end up with this injury, unfortunately, just because their mechanics are not so good and the general strength and conditioning isn't there. So you can see nicely in this picture how the right Achilles is thinner compared to the left. And that's for the reasons that we spoke about earlier, where as this is healing, we actually tend to lay down new tissue rather than heal the older tissue. And that means that we end up with a thickened tendon, and that generally stays that way, even once there's no longer any symptoms around.
Does that affect mobility when it gets that thick?
If you follow a good rehab program, no, because you'll get the mobility back. If you don't go through the rehab program, then yeah, often you see a deficit or a decrease in that ankle mobility of pulling the ankle up and down. Yeah, so that's why another reason why rehab programs are very important to get in the first place and then follow all the way through.
Yes, doctor.
This is what I speak about all day. So we can see the same types of treatment, and then sometimes it can even get down to that surgery point again after about 12 months. And we see a couple of words there. So debridement is taking away the dysfunctional tissue, or tenotomy means when they actually divide the tendon to allow it to move and kind of slide and glide more through its sheath, which we're going to talk about next. Good. So tenosynovitis or tenosynovitis is the inflammation of the tendon sheath. You see this mostly in the hands and feet, common in carpenters, dentists because of all the fine movements that they need to do, musicians for the same reason, and office workers with lots of typing. You can often see it as well in conjunction with other conditions, and especially kind of inflammatory conditions or such as like rheumatoid arthritis or diabetes, where we have that poor blood supply. Probably the most common one of this is known as de Quervain's tenosynovitis, and this occurs in these two muscles of the thumb that you can see in the picture here. So they're called abductor pollicis longus and extensor pollicis brevis. So we had a chat about how the muscles are named. So abductor means that it's a muscle that abducts, or so if you think of abduct means to take away. So if you imagine you're being abducted by aliens and they've got you by the arm, you've abducted your arm out to the side to be taken away. Whereas adduction would be the opposite of that, and that's when the arm comes across the body. Pollicis, so if we see that word, that's referring to any muscle going to the thumb. And we see this de Quervain's more often in women over 40 years old, or often during pregnancy, or when there are during the time when the babies or children are young and needing to be picked up a lot. Okay, we'll now have a look at fascia. So I've mentioned this briefly in the past, but fascia is connective tissue. So it's like quite a fibrous tissue, and it packages and protects our muscles, as well as our organs and many other features of our body. But we're speaking about muscles, so we'll think of it in that way. So it packages and protects them, and it groups muscles together. And this is really important because it creates compartments, and that can help to stop spread of infection. So when we had a look at the arm earlier and we spoke about with tennis elbow, how we have the muscles on the back of the arm affected, whereas for golfer's elbow, we have the muscles on the front of the arm affected. So we've got fascia that surround all the muscles in the back of the arm and create what's called the posterior compartment, posterior meaning on the back, and we have fascia which takes all the muscles on the front of the arm and creates the anterior compartment of muscles. The other thing that tendons do is they form these things called retinacular. So if we have a look at this picture of the ankle and over the front there where you can see the white fascia, and that's our retinacular over the front there. And that stops at our wrist and ankle particularly so we'd have one on the back of the wrist here. As we move our wrist and I come up or down, instead of as I come up, all of the tendons just jumping up and sitting up like this, the retinacular holds them down at my wrist. So there's a couple of conditions that the fascia becomes quite important for. Plantar fasciopathy, which you might have heard referred to as plantar fasciitis. It's been changed away from that. Similar to what we spoke about earlier, there's actually very little inflammation in most cases. So when seeing as itis represents inflammation, the name's just getting changed to represent the condition better as we know more about it. For this one, get pain right there under the heel like the picture shows in red. It's really particularly sore in the morning and then with repeated weight bearing. So it's, can warm up and feel okay as you're walking, but then start to get really sore as you go on. And this is due to a chronic or repetitive overload. Usually there's biomechanical factors, or if that comes into sporting, then training factors that are occurring. It can happen in increased body mass index, so increased weight, and that can occur during pregnancy naturally as it's meant to. It can be a common time to get it. But it's most common in 40 to 60-year-olds. Usually it is just one-sided, but for some unlucky people, they can have it on both sides, or one side gets better and then they get it on the other side, which is, yeah, unfortunate in that case, because then both your feet hurt as you're trying to do all your daily things. Very occasionally you can have an acute form, say if you jumped off something quite high and landed heavily on your heels, that may cause it. Investigating it, again, usually we start with an ultrasound. If we need more information or it's not responding, then we can look at an MRI. Treatment protocols are much the same. Manual therapy, shockwave, rehabilitation exercises, address the reasons why it's happened. If it's still going after 12 months, then start to consider surgery. Most people might have heard of shin splints, which is the common name for medial tibial stress syndrome. So that's meaning that the inside, the tibia, is the bone on the inside of the lower leg, and we're just saying on the inside surface of that we've got a stress occurring. And that occurs at the junction where the fascia is meeting up with the bone. So if this goes on for too long, we can get poor bone remodeling and then that progression onto stress fracture. Jump back to the last webinar if you need a reminder on stress fractures for that one. For this, we're going generally straight to an MRI, CT if we can't have an MRI to get the best information. We need to address the risk factors. So why has it occurred? And usually a period of rest is needed for this one. For a lot of the conditions that we've been speaking about, we generally don't want that much rest. We want to keep using the area, and that's really changed in the last by a few years. I mean, 10, 20 kind of years, where we really don't want to rest areas totally. We want to keep using the area as much as possible, so we keep lots of good circulation, so we keep that nervous system really active, and so, which we'll talk about next time, we don't start to develop kind of chronic pain conditions as readily. So we want to keep using the area as normally as possible, rested in the ways that we need. But for this one, often we do need quite a lot of rest to let it settle down, because it does actually have quite a bit of inflammation, and we want to stop that inflammatory cycle that can start occurring in its tracks. So here we will often look at those corticosteroid injections to really help with that. Good. A lot of those risk factors are the same as we've seen in others, with changes in footwear, the surface that we're walking on or training on or standing on at work, higher body mass or female, really common in runners and in dancers. If you think about how much dancers are on their toes and how much strain is going through their legs, they're another group that often get these. And then our last condition is called compartment syndrome. So we've just spoken about how fascia creates compartments. So what if we get increased pressure within this compartment? So this may be because there's a lot of inflammation in the area, or if there's been a rupture of some blood vessels and there's a bleed in the area, or if there's something like burns that have occurred. There's a whole range of factors, but essentially what happens is we get this increased pressure within the space, and that's going to cause a reduction in blood flow. And along with that, nutrients and especially oxygen supply to the tissues, particularly our muscles and nerves, are what's going to cause the pain. So we get, because it does cause changes in the muscles and the nerves and in the blood vessels, we'll get pain, pulses will be decreased, we'll get color changes, so the area might become quite pale. We could see the swelling that's occurring, and because the muscles aren't working well, then weakness. For this one, we use Doppler ultrasound, so that's one of our functional forms of ultrasound, so we can see what's happening with the blood flow and with the rest of the fluid flow through the area. If this is mild, then we can remove the contributing factors, such as if it's in the lower leg, running on it, if it's in the arm, using the arm so much, and let the inflammation go down. We could use some pain medication or anti-inflammatories to help with that. If there is another factor that's causing it, such as infection, treating the infection or whatever might be, there is obviously important. If it's really severe, because we don't want, because we don't want those nerves and muscles not receiving blood flow and oxygen for very long, then it may progress to surgery. And in severe cases, it actually is a medical emergency. So they will take you in for emergency surgery to address that.
So I'd like to say a big thank you to Dr. Amy Lawton again today. Thank you, Amy.
Thank you for having me.
Thank you very much. And also a big thank you to Clarissa and Carly, always providing us with the technical support. Have a lovely, lovely evening, and we hope to see you in a couple of weeks for the third series for the third webinar in this series. Like we said earlier, that's understanding pain and concentrate on the nervous system. So get online and register. All right, thanks very much, and we'll see you next time. Have a lovely evening.
Thanks, everyone.